Today I'm going to discuss the use of intraoperative navigation as the preferred technique, or really, why would you only go halfway when you can go all the way? These are my disclosures, relevant for my role as a design surgeon for a shoulder arthroplasty system. Shoulder arthroplasty is a challenging surgery. We have limited access with limited bony landmarks, and the key for the ingredient for success has been a strong surgeon experience with a long learning curve. Because what you see is not necessarily what you get. The glenoid face that we see at the time of surgery is not necessarily representative of the glenoid vault anatomy. And implanting a glenoid component, either for an anatomic or reverse, depends on really understanding the anatomy, particularly the deformity involved. So for accurate glenoid component placement, you can do it based on anatomic landmarks, preoperative planning systems, patient-specific instrumentation, and intraoperative navigation. And to me, you really have to have experience and proficiency with the first one based on anatomic landmarks before you venture into numbers 2, 3, and 4. So there's no doubt that improving placement of the glenoid component can be obtained with preoperative three-dimensional planning and patient-specific instrumentation. However, why go only halfway? Did Christopher Columbus go halfway across the ocean and turn back? No. Did Sir Edmund Hillary stop halfway and walk back down Mount Everest? Of course not. Did Louis Pasteur stop after developing pasteurization of milk and wine? Of course not. He developed vaccines. So why would we only preoperatively plan and not intraoperatively navigate? Combine the two, to me, for right now, is best of both worlds. Because combining pre-op planning with intraoperative navigation gives us a method for implant selection, component position, and placement with the potential short-term and long-term benefits. And there's no doubt that it's superior to preoperative planning alone. Studies have been done showing surgeon accuracy, comparing it with preoperative planning versus intraoperative navigation, and the variation is much smaller. So intraoperative navigation combines a preoperative planning tool to visualize the implant on the bone, select the implant, adjust the positioning, and minimizing the risk for perforation. Cases like this, where we have to implant the glenoid component with a pre-existing screw from an old Latarjet procedure, you can plan it and execute it as you would wish, as evidenced by the intraoperative navigation view and the postoperative x-ray. Take this 50-year-old male with significant osteoarthritis with glenoid erosion posteriorly. Clearly, this is a challenging case because of the deformity. Preoperatively planned to have a posteriorly augmented glenoid component positioned here on the glenoid, and then intraoperatively utilized, right? The navigation allows us to position the component, the augmented component, in the position we need it to be in, to ream appropriately to match the glenoid component, utilizing off-axis reaming, and then implanting the component in the manner that we would wish to, as shown in this x-ray, the augmented component in place. So I've been using intraoperative navigation for the last 3 years. We wrote up my experience with respect to the impact on my practice. I looked at the first 100 cases I did using navigation, and looked at the last 100 cases without navigation, and specifically looked at the impact on my OR time and implant selection. Initially, for the first 25 cases, the OR time was about 13 minutes longer. For the last 25 cases of the 100, it was only 4 minutes longer. So there is a learning curve, and the impact on OR time is minimal. I was very surprised to see that my selection of implants changed significantly. I had a much higher percentage of augmented implants, both for anatomic and reverse shoulder replacement. And I think this is a commentary on the ability to recognize and address the deformity that you really cannot do, right, unless you really understand it and you preoperatively plan it and use the navigation intraoperatively. So for me, the impact of navigation on my practice, I believe it has made me a better, or maybe even a much better, shoulder arthroplasty surgeon. Navigation has removed a lot of the guesswork when I'm working on the glenoid. With all the experience that I've had through the years and all the replacements that I've done, there is still a certain amount of guesswork, educated guesswork, but guesswork nonetheless. That's part of it. I think the navigation continues to be important, although it's essential to evaluate every step before you perform it, because you really have to understand what you're doing. You can't rely completely on what these systems are telling you. I really believe that the integration of preoperative imaging and planning, intraoperative navigation, intraoperative findings, and surgeon experience provides much more as a combined benefit than the sum of the individual parts. So for me, the positives of intraoperative navigation are the detailed preoperative planning, integrated with operative implantation. The system I use is user-friendly. I've shown it has a short learning curve, and it has reproducible results. There are negatives. It takes additional OR time, which to me has been worth it. The increased cost per case really has to be decided on an institutional basis. And what we really don't know is how planning relates to the actual accuracy. But we're trying to determine that now with the data we have. And most importantly, what are the impact on the outcomes? How does this affect clinical outcomes as well as implant survival? That's really the information we need as we evaluate all this new technology. We're in the process of determining that, and I hope to be able to report that using our database sometime in the not too distant future. Thank you very much.